Okay, so we are switching to English to welcome Kathy Kinlaw. Her presentation is Ethical Challenges During the COVID-19 Pandemic, Multidisciplinary Healthcare Professionals' Perspectives and Vaccine Decision Making. Thank you so much for being with us this afternoon. The floor is yours for 30 minutes and then we'll have 10 minutes of discussion.
Thank you so very much. I want to particularly thank Drs. Leo Kutalek and Clément Tarantini for the invitation to join today's discussion. I thank you also for allowing me to join you remotely. I would much prefer to be with you in person, as you might expect. I appreciate everyone's help in getting this program up on the screen also this morning. So the COVID-19 pandemic obviously has affected patients and families and loved ones and healthcare professionals and really each of us around the world, both during the last 2 years and continuing today. The intersection of ethical theory and ethical approaches with the realities of the implementation of ethics in a public health and clinical crisis have really shifted roles and responsibilities in powerful ways. Much pandemic planning occurred earlier with the H1N1 influenza pandemic preparations in 2009 and 2010. And I had the opportunity to work with the United States Centers for Disease Control and Prevention on much of that planning. And interestingly, many states in the United States created statewide crisis standards of care plans at that time. So now we move forward to the COVID pandemic in 2020. And at that point, most states did not actually implement their plans early in the COVID-19 pandemic. We did not continue the momentum from that discussion. So in March of 2020, pandemic response began on a community or institutional level. And I received such a call to begin working on institutional guidance at that time as well. So working with a team, I had several ethicists, but also a number of critical care practitioners who worked to develop ethics guidance for allocation of scarce resources and also triage processes for actually implementing our guidance in case that difficult choices were required. Of course, we hoped we would never need to actually use them, but we wanted to have what we hoped would be as fair and consistent a policy in place as possible. I will also say that important to us working in ethics was the concept of collaboration and information sharing. And so we worked with healthcare systems, primarily ones in the southeastern United States, through a group we had already been working with for 2 decades called the Healthcare Ethics Consortium. And you see the website on this page, which is hosted by the Emory University Center for Ethics. We also had meetings bi-weekly with bioethics program directors from the United States and Canada through a group called the Association of Bioethics Program Directors. And again, you see the website there in case you would like to access it. And so really our initial goal was about creating ethics guidance. And we utilized a number of the principles or guiding approaches in ethics that we use frequently in the clinical environment, but that of course had different meaning within a public health crisis like the pandemic. And so the principles that we primarily were really beginning discussion was, what would it look like for us to really be respectful of persons, to respect the dignity of all persons when in a public health emergency, honoring the treatment preferences of every patient, of course, might not be possible. We wanted something that would apply consistently across all individuals with a strong belief that each life has an equal claim on being saved, that all are eligible. We also wanted to, of course, think about what was in the best interest, beneficence and non-maleficence, and what would not cause harm. So how do we maximize benefits and minimize harms to the whole community, not just to each individual? And then justice considerations, fair stewardship. How do we distribute sources in scarcity? And how do we really be thoughtful about equitable distribution of benefits and burdens and not exacerbating existing disparities in healthcare? So all of these considerations, if you will, were going into effect in our thinking about ethics guidance early on. We also found that a number of clinical concerns were being raised, some early in the pandemic and some along the course of the pandemic, which raised rather urgent ethical questions, and which we tried to respond to rapidly. So somewhat early, the question of whether we should continue to do cardiopulmonary resuscitation, or CPR, as usual, or should CPR not be done because it was increasingly risky, particularly intubation and aerosolizing of the virus. And we were able to quickly review that with clinical care specialists and make recommendations. How should we approach advanced care planning, or the completion of legal documents, advanced directives that would allow a patient who had no longer had decision-making capacity to have their preferences followed? What do we do about patients who were unable to have family and friends at the bedside in the middle of a pandemic where viral transmission was of concern? And then how do we think about transparency of information in the middle of a very difficult time, of course, for all? And so in the midst of this, we were happy to receive some funding in order to allow us to actually survey our healthcare professionals to share their experiences. And so we had a survey on ethical challenges. It was actually administered in June of 2021. It was an online survey with multidisciplinary participation across physicians, nurses, respiratory therapists, and the whole scope of clinical team members. And we had 1,380 responses, which we are still analyzing. The respondents came from one very large healthcare system based in Atlanta, Georgia, in the US, with 10 hospitals and a large outpatient clinic, and also it's an academic health center with other schools within the university environment. And our primary goal, again, was to try to capture the experiences and ethical challenges of healthcare professionals during the pandemic to date, at that point, of course. And so, again, a multidisciplinary group of respondents. We had a large number of nurses. I think 54% of our respondents were nurses, 15% physicians, and then you see a multitude of other respondents, which was wonderful to have input that was truly multidisciplinary. We also found that there was a range of respondents' years of experience that's completing their training in their profession. And a significant percentage had over 20 years of experience, which was sort of powerful to pull from in the midst of pandemic and pandemic decision-making. And so with my time with you, I want to simply focus on 3 areas of ethical concern that were highlighted in our survey. So it's not comprehensive, but these are powerful with lots of ethical implications. One is the prevalence and role of fear and of being at risk, and the relationship with responsibility or professional duty. The second is the questions around availability of resources and the ethics of allocation. And I know there have been some speakers earlier in the day who shared their experience there as well. And then a third one, which I found one of the more troubling ethical areas of practical implementation, was limitations on visitors who could be with a patient during the course of their illness. So this is merely a graph of the hospitalization rates in the United States throughout the pandemic. The red vertical line here represents the timing, approximate timing of our survey, the survey I'm describing. So you'll notice at that time, which was in June again of 2021, June and July, that peak activity at that point had occurred during December of 2020 and January of 2021. And of course, as we all know, there's been much activity since that time. So I'm only capturing in the survey what had occurred before June of 2021. So when asked at what time respondents had their highest concern about risk of participating in a procedure, such as intubation, where aerosolizing of the virus was concerned, as probably not surprised, the early weeks of the pandemic was a time of most concern for most of our survey respondents. Everything was evolving, information was evolving, and I think most of us were trying to react to the rapid transmission of the virus and patients coming into the hospital. We also had a significant number of written comments from respondents, and I want to share just a few of those with you. So respondent 1, by far the most challenging part of my ICU career, particularly the first few months. No one really had any idea what was going to happen. I rewrote my will in case I died. I assume many others did the same. I give great credit to our nursing staff and respiratory therapy who would spend hours in the room, risking themselves much more than I think most physicians did. And I believe this is from a physician respondent. Second respondent, even with protective garb, I found myself treating ICU patients with COVID illness an anxiety-provoking experience. That did not stop me, however, from fulfilling my Hippocratic oath. So there was some sense of professional duty. I'm not fully sure of what they intended to imply by the Hippocratic oath, but certainly a sense of professional duty this respondent was indicating. And a third respondent, my concerns were highest in the earliest weeks of the pandemic for the following reason. Little knowledge was known about the virus. PPE, or personal protective equipment, was scarce. Exposed clients were sicker at that time. And the respondent says, I had asthma and was unvaccinated at that time. And again, however, I always performed my duties as expected and per facility protocol. So some sense I had a professional duty and moved forward with trying to honor that. So while we are analyzing comments further, and we're analyzing for thematic content now, there is an indication of significant fear for those who are responding as they continued working, a great sense of uncertainty from lack of knowledge about the virus, particularly early in the pandemic, but also from changing institutional practice or policy about infection prevention. Just for example, there are comments related to what were the appropriate ways to don or doff, to put on or take off one's protective equipment or one's PPE seem to change. Guidance related to the wearing of mask and what type of mask and how to care for masks between patients when we weren't sure we had enough PPE to replace masks on a regular basis. And then evolving knowledge about clinical practices. Many of you who may be clinicians will certainly be familiar that it became known that proning or simply lying someone on their stomach was helpful for many patients. That wasn't even known early on. So there was evolving information. And yet a great majority, I would say, of physicians and nurses and other healthcare professionals reported continuing to accept their professional responsibility to provide excellent quality care to patients despite risk and fear. But we also are hearing, both in the survey and since the time of the survey, many healthcare professionals wanted much more support from healthcare leaders and institutional clinical leaders. Many healthcare professionals described feeling alone. They were in the room caring for patients on their own, that they were exhausted and they struggled with moral distress. And in many cases, people reported that their sense of trust that the hospital or institution was looking out for them was disrupted or broken. One of my colleagues actually indicated this by saying, none of us were trained for this. And this was a dramatic comment, but she said it needs to be treated like a shooting, like a mass casualty. We were not ready for this. And so a willingness in the face of fear and risk to continue care, but also an exhaustion and a deep sense of moral distress occurred for many of our respondents. And so that was a major theme. And I also want to turn a little bit to resource allocation and triage implications, which we did talk about in the survey. So the level of concern about the possibility that limited resources for patient care would occur, the resources would be exhausted, was of highest concern early in the pandemic. And then a second highest time of concern was in the busiest weeks of the pandemic. And again, at that point, right? So this was again in January of 2021, that would have been the second highest time. And then we found that these were some of the areas that respondents were particularly concerned that they were not going to have adequate resources for. So the very first one was nurses. So our clinical staff, but nurses in particular. And I have to say, many of us working on early preparation of ethics guidance did not focus on the potential shortage of staff. We were more focused on running out of critical care resources like ventilators, et cetera. But nurses were the major concern for many respondents. Then PPE or personal protective equipment, then ICU beds. So many of our facilities, and I'm sure this is true in other arenas around the world, but we were running out of ICU beds, and we could take over units and turn them in, if you will, to COVID ICU beds, but we were concerned about how long we could do that. The concern about shortage of other team members like respiratory therapists or individuals to simply transport patients, for example, was high. Dialysis machines and ventilators, fairly high on the list, but again, after some of these other concerns. So the question of whether we anticipated well what it meant to have to deal with scarcity, I think is a powerful question for us in our ethics preparation. How aware were respondents of allocation planning at the healthcare system? As I said, in early March, we were getting calls and beginning to work on ethics guidance and in some great detail, creating a pathway for decision-making. But how aware were respondents of this? Well, the respondents indicated that their own knowledge that a detailed procedure for allocation and triage decision had been developed indicated that many were not aware or were only vaguely aware that this work was going on. Similarly, the awareness of their colleagues in the unit in which they primarily worked was also pretty low. Many were not aware or were only vaguely aware. And even less awareness among colleagues that there was an implementation effort ready. In other words, there were multidisciplinary groups of healthcare providers who had been in training to actually have to make these tragic triage and allocation decisions if needed. So I think one of the lessons here for us was that there was a clear opportunity for increasing awareness and also improving our communication really across the system. And then the third area I want to talk about briefly is the limits on patient visitation. It was fairly frequent for our respondents to indicate that they had communicated with a family member or what we call a care partner, not necessarily a family member, but maybe a friend of a patient who was very upset because they were not able to visit the patient in person. And by the way, this was equally true for being unable to visit patients in the hospital who did not have COVID-19, as it was for family who could not visit their patients with COVID-19. Of course, the patient visitation limits were in effect for everyone in the hospital setting. Also, respondents reported frequent experiences of caring for seriously ill or dying patients where visitation was limited. And that was very difficult for many of our respondents. So for example, 47% of our respondents reported that they had a COVID-19 patient or many dying without family, and that included very frequently or often or sometimes. So it was a usual event, unfortunately. So in terms of some comments on visitor limitations, these are just a few. One person said, I found these issues the most difficult of all of the problems. Ill patients without family support who would periodically themselves would want to sign out AMA against medical advice because of their unhappiness about being alone and ill. So the impact on the patient themselves not wanting to be dealing with this illness all alone. A second comment, any patient who had to be admitted to the hospital deserved to have a care partner with them. So the idea that it just was not right or fair for a patient to be alone. A third comment, when visitor restrictions were more rigorous, at times it was very difficult to try to ease the minds and hearts of patients' family members. And then a last comment, having family members scream at you because we were considered to be lacking compassion because the policy was that no family members or care partners could visit. And then in terms of the presence of the care providers dealing with end-of-life issues, one comment, making phone calls to family members prior to the patient being intubated and having them say their final goodbyes, patients crying for me, then again, the nurse or the physician, not to leave their room and not to leave them alone while my other patient is dying in another bed alone with no family members able to come to the bedside. And so I think we see very clearly this return to moral distress, an experience of moral distress. And here we define that within the survey as when one knows the ethically correct action to take or care to provide, but situational constraints make it difficult to take that action or provide that care. So respondents clearly indicated that they experienced moral distress during the pandemic at a frequency much higher than prior to the pandemic. So for example, 48% of our respondents indicated they experienced moral distress very frequently or often during the pandemic as compared with 12% prior to the pandemic. And so as a beginning place to our maybe a few moments of discussion, I think there are some important areas of ethics lessons or ethics reflections. One was that our system and our institutional responsibility to engage and listen deeply to healthcare team members was found inadequate by our healthcare professionals. Our colleagues had and have significant moral distress. We are all experiencing shortages of healthcare professionals, especially of nurses, and dealing with the aftermath, I think, of this moral distress and the inability to effectively respond to it during the pandemic. Secondly, the power of family and partner presence in a patient care. In ethics, we often talk about discussing or utilizing a least restrictive measure that is effective. And one important place for us, I think, and a potential maybe for innovation, is how might we respond in such a way that partners or family members are not totally restricted from being available. I know we have to balance our safety concern about transmission of the virus, but we have to balance it with human kindness, the power, acknowledging the power of familial support for a patient, and of course the benefit for the patient, but also for the family themselves, and sometimes for our healthcare professionals. And this is an area that I think we must continue working on. And then with allocation, I feel strongly that anything we can do to maximize preparedness to minimize the need for allocation is important. So now, of course, is the time, even as we're continuing to deal with COVID, to review and reflect on our allocation documents, our ethics guidance, and not to let our momentum to address these difficult questions decrease. Again, I saw in H1N1 in 2009 and 2010 so much effort going into preparedness, and then there was not much attention given to that as the years went on, and we began again in some ways with COVID-19. Now is the time not to let that momentum lack. I think there's concern about the potential for deep conflict between allocation, with some patients perhaps not receiving needed resources. That's a very difficult issue for our healthcare colleagues. And how do we weigh that with our sense of professional responsibility to individual patients? Can we improve our processes? And then an area that we could speak at length about, really, and I've only touched on here, are concerns about inequity in care. And are we, and in what ways are we exacerbating or increasing our health disparities in this process of allocation planning? And so with that, if I can move to my last slide here, which is just to thank you for this opportunity to join you, and hope that I can continue to learn with you. Thank you very much.
Thank you very much for this very thorough presentation. So I'm sure we will have a few questions.
Thank you for an excellent presentation. I'd like to know what you think about Victor Mondori, least disruptive medicine. Do you were somewhat inspired by him, or is it just the case that least restrictive measure are sounding a little like his less disruptive medicine? He's a diabetologist, obviously, so it's different.
Thank you. What I heard that intrigued me mainly was this question of how healthcare professionals might actually talk with the patient in terms of actually choosing treatment. Is that correct? Am I hearing you correctly there?
Disruptive for the patient's life and family life.
Being able to visit, yeah, I think I have that. Yes, I mean, I will tell you that most of the institutions I was in conversation with moved very quickly to the value of not transmitting the disease and spreading it to others, and so moved to a complete shutdown, if you will. No one external was allowed into the hospitals, certainly no family members. There are so many, I'm sure you all could tell me as well, tragic stories of family members, just wanting to have 5 minutes outside of the patient's room to say hello to them as they were dying. And I find that egregious. At the same time that I value and understand, we did not want to risk the virus spreading to others, particularly early on when there was so much unknown. So I feel the tension. I then began to see, and I'd love any stories that you have to say, but some institutions trying different approaches, whether, for example, allowing one family member who had tested negatively to come into the room and stay in the room. They were unable to leave, and if they ever left, they were unable to come back in. Just to be with the patient on an ongoing basis. And that was so powerful. And again, this is anecdotes, particular stories, but so powerful in terms of helping the patient not feel abandoned, helping them actually, if you will, fight the virus. They felt more energized by the family presence and care. And in some cases, the family member was able to actually help the team in some of the day-to-day ways in which the patient needed care. So there are stories that are, to me, of hope about a less restrictive way for us to respond. But I'd love to hear from you all as well.
So we have 2 other questions at least.
Thank you, Professor Kinlaw, for your presentation. It was very interesting. My name is Alain Letourneau. I'm participating in this conference. I'm from Canada. I don't know if you can hear me. Are you good for the sound?
Yes.
It's okay? Okay.
I can.
So I just want to make a connection between what you just presented and some previous discussions we had here in the room. When in the beginning of your presentation, you mentioned issues about triage, and then you talked about, like, let's say, utility for the common good. We could, like, position this that way. It's not the exact terms you use, but it had to do with that. And there was also in your slides some preoccupations that we can associate with justice issue and equality issues. So maybe I would like you to expand a little more about all this problematic, this question of how do we actually give ourselves criteria to be able to do triage in a fair or acceptable way. That would be my question.
Thank you. Thank you for your good question. And I wish I'd heard everything earlier today. I hope it's recorded so I can go back and watch it. Yes, we, as I think most of us working in ethics in a clinical and decision-making role, really struggled with this. We wanted to have as consistent and standardized a process as possible, but it felt very sort of one-sized, if you will, in terms of being able to be responsive to all of the kinds of issues that patients and teams were dealing with. But we did move to 2 criteria in creating sort of an allocation scoring mechanism, as did many institutions. And we were in pretty constant conversation with a number of bioethics program directors from the United States and Canada. So we were able to listen into how others were thinking about it at the same time. And so, as you know well, I am sure, we moved toward what was the likelihood that this patient would actually survive this particular hospitalization. That became sort of number 1 in terms of trying to create some mechanisms for clinically scoring that for every patient. And the struggle there to me was making sure that we were not using existing clinical projected models too quickly. For example, the SOFA score, so the sequential organ score, was one that was used often. We did a lot of delving into whether it was a score that had any relevance to the kinds of questions we were asking about these particular patients. Would it actually make a difference in terms of survival to discharge? Then we pulled other clinical guidelines from a multitude of disciplines with our critical care colleagues to try to see could we refine those in ways. And then I will say in the actual allocation score, we were very conservative. So we tended to not score anyone low unless we absolutely had so many clinical indicators that it seemed reasonable to do so. And of course, we were very fortunate that we did not ever have to implement our allocation triage process, but it would have been so difficult if we'd had to do so. And just a word to the triage process. So we did have a very well-developed triage process. We had a committee of about 30 people from a variety of disciplines who met and trained. We went through implicit bias training. We did a lot of looking at particular clinical scenarios and scoring them in small teams and then coming together to really debrief whether we thought those were reasonable and fair scores. And then in our triage process itself, we were moving toward having teams on call, and the teams had to be at least 3 people from different disciplines with ethicists available as needed for being on call 24 hours a day for a certain period of time, and then another team coming on. And again, I just am incredibly thankful that we never moved to that point. So a little bit of information, happy to share more with you afterwards as well.
Hi Katie, his families, you are so kind to invite me and my colleagues to your international course of bioethics and COVID. I will have 2 questions on the 2 other topics of your presentation. First, I was very interested to see that also in the US, the family and friends issue was so high in the ranking of ethical issues during the crisis that it was so important issues in your survey. We had in France, after these questions, we had some families and some associations asking politicians that it should become mandatory in the law that family could visit people in hospitals or in nursing homes even if there is a pandemic. Did you have something like this in the US? And the second question is more ethical maybe. It's do you have an analysis of this place of family and friends in these ethical issues? What does it say about the caring relationship between a patient and a physician or nurses when families and friends appear to be so important even in a crisis and when there is so much risk? And maybe the second question is shorter. It's about fear. You described people experiencing fear, uncertainty, loneliness, but you said nevertheless, they said we performed our duties. One could be surprised by that. Everybody say that we are living in individualistic societies, that moral rules do not play any role anymore, and we see that people with very high pressure, alone, knowing not a lot, with a lot of fear, they perform their duty. How do you analyze this?
Thank you for your good questions. In terms of your move in France to actually address the visitation issue with public policy, there have been many discussions and no efforts to actually change law even within a state that I'm aware of. I'll do a little digging to make sure that there's not an update on that. But my guess is those questions will move into the policy realm. There is certainly enough outrage in the public for our governmental bodies on a state level to have heard frequently from patients, or more likely from families, about this. But there's not been an overwhelming public policy effort on a state level or on a federal level at this point. And again, I think just a component of that is making sure that we do come up with some models, some innovative models that we think do take seriously the transmission risk and the protection of others, but also, again, recognizes the humanity of the individuals who are affected, both the healthcare providers and the family members and the patients, of course. So yes, I mean, I think the fact that that was a high issue for our healthcare providers, you know, I think it really does speak about the human nature of our healthcare providers, and frankly, for many of our healthcare colleagues, why they went into the profession was a deep sense of being there for patients and caring for patients. And so to see the impact that the lack of care partners or family members had was just absolutely met them where their own sense of who they were, their personal and professional identity was really damaged, I think, in the midst of not agreeing with that policy. And some other parts of the survey, we asked about how often individual respondents were involved in asking for exceptions to this policy within the institution. And of course, I don't have my statistics in front of me, but there were certainly a number of times where that was the case. But I think it's an expression of the angst and the moral distress that providers were going through in participating and perhaps feeling complicit in applying this policy. And again, many narratives, we talk about narrative ethics, many narratives here that I think will be powerful for us to explore as ethicists and as clinicians going forward as we think about change, institutional and maybe public policy. And then your last question was related to fear and risk. You know, I think it does speak again to our humanness, right? The reality for many of us, I mean, I'm a clinical ethicist, often seeing patients in the hospital setting. I am not in the room every day, did not need to be in the room every day with a patient who had COVID. But I could just see what it was doing, again, to a sense of what was possible for example, a nurse who was in the intensive care unit, who was unable to provide the type of care, the humane care, the kindness of care, but also just available resource care to patients. And so at the intersection of their own identity as a human being and as a healthcare provider, how did one struggle with that? I think people endured, people were committed to staying in their role and did in so many cases. And now I think we're living with, many of them are living in, we're seeing the aftermath of that decision to stay true to their professional responsibility as a deep part of their own sort of personal sense of identity. And I think there's real questions related to what we ask of our healthcare professionals. Are there limits? And again, what do we do to support people who continue to make the decision to continue to care? And again, I'm sure we could talk at length about that. I think about travel nurses, people who left to go to other areas. And then I think about my colleagues who've been ICU nurses, intensive care nurses for 20 years who stayed and are, if you will, dealing in a different way with the aftermath of having done so, of having stayed despite all odds, if you will, while others have left either the profession or left to travel to other areas. So I think there's a reckoning, if you will, coming for us both in terms of support of individual healthcare professionals and rethinking our institutional practices and policies.
Thank you very much.
All right, thank you so much, Kathy. We were pleased to have you here with us. And that was the last presentation of the day, so back to Leo Kutlek.